Second speaker is an assistant professor of medicine at UCLA, has one of the more impressive CVs that I read for this conference, and holds so many leadership positions at UCLA, including directing the UCLA's GI Quality Improvement Program. Folasade May is going to tell us about when to start and when to stop colorectal cancer screening.
Thank you very much for that introduction and also for the opportunity to speak today. And I have to say, it's a pleasure to see you all in person after this past year, and I'm very honored to be here today to present this topic. Dr. Azaka provided an overview of colorectal cancer screening tests and surveillance as the first part of this overview for colorectal cancer screening. And I'm going to provide a talk that talks about two different but related topics. If I can get my slides to advance here. There we go. First, quickly, let me just provide my disclosures. What I'm going to tackle is a bit of a deeper dive in the updated United States Preventive Task Force colorectal cancer screening guidelines. And then I'll also talk about some advancing technologies in colorectal cancer screening. So we'll start with the new screening guidelines. So it's no secret that in May of this year, the United States Preventive Service Task Force issued or updated its guidelines for colorectal cancer screening. This is the first revision in the guidelines since 2016, and they depart from the prior discussion or recommendations in one major way. The United States Preventive Task Force, for the first time, has formally recommended that we screen average risk Americans who are age 45 to 49 for colorectal cancer screening. They've had 3 levels of recommendation. They've kept a grade A recommendation for screening individuals that are age 50 to 75. They've added a grade B recommendation to screen individuals who are 45 to 49. And they've maintained their grade C recommendation that we should selectively screen individuals who are age 76 to 85. These guidelines reflect very strong data that continue to support screening individuals who are 50 to 75, however, also reflect that the data is not as strong for the groups that are age 45 to 49 or 76 to 85 for the benefits for screening. It's important to understand the grading system that the USPSTF uses for these recommendations. They have a 5-level tier of grading that they use for all of the recommendations that they use for preventive services. Grade A and Grade B recommendations are services that they strongly recommend. Grade A with having the most or highest certainty that there is a net benefit of the recommendation. Grade B recommendations have high certainty that the net benefit is moderate, or moderate certainty that the net benefit is moderate to substantial. Grade C recommendations are selectively offered. Grade D recommends against the preventive service, and I states that there is insufficient information or data to make a recommendation at all. So reviewing what we've seen most recently for colorectal cancer screening, they're stating grade A for 50 to 75, as we've seen previously. And this new group, 45 to 49, is recommended overall, but with a grade B recommendation. This distinction is important because recommendations that come from USPSTF that have a grade A or B recommendation must be covered by non-grandfathered private insurance companies, Medicare, and Medicaid. So once the USPSTF puts that stamp of grade A or B, then patients will naturally have insurance coverage for these services. The USPSTF also included in the most recent guideline a statement about the recommended screening strategies, and Dr. Azaka has provided a bit of a preview of this. They've recommended several strategies and suggested that all of these are equivalent approaches to colorectal cancer screening. These include high sensitivity guaiac fecal occult blood testing annually, the stool DNA FIT, which can be done every 1 to every 3 years, CT colonography every 5 years, Flexible sigmoidoscopy can be used as a screening strategy alone every 5 years, or if combined with FIT, it is performed every 10 years. And certainly, colonoscopy, as we offer, every 10 years. So there are a variety of factors that the USPSTF recommends that we consider in picking one of these tests in a decision with our patients. Factors to consider include the frequency of the test, the location that the screening is performed, for example, at home versus in an endoscopy unit. In addition, whether the test involves stool-based or direct visualization, the need for anesthesia and sedation, and whether a follow-up procedure might be necessary if the result is abnormal. This is again emphasizing, as Dr. Izaka stated, a two-step process for many of the screening tests that we use. What do I mean by a two-step process? This is the reality that for most screening tests, if there is an abnormal result or a positive result, that test must be followed up by a colonoscopy to complete the screening process. And many of us, upon seeing the draft statement from the USPSTF in October of last year, were very concerned that there was not enough commentary about the required second step for screening for many of these tests. Fortunately, in the final draft that came out just last month, they have made it very clear that all of these tests that are indicated here on the right side of the slide must be followed up with colonoscopy to detect polyps and colorectal cancer to be considered a completed screening process. Why is this important? Why are both Dr. Izaka and I talking about this? This is important because what we've seen over time is an increase in the proportion of non-colonoscopic screening. And as we start to screen individuals who are 45 to 49, we think there'll be even more use of FIT testing, stool DNA, CT colonography. So we must emphasize to patients on counseling about these tests initially that if they are abnormal, they will need a second test. And in particular, many of us are working on policy at the state and national level to make sure that they have insurance coverage for the follow-up exams. The motivation behind the change and the most recent guidelines comes from the changing epidemiology of colorectal cancer. Since the early 1990s, we've seen an increase in colorectal cancer rates in individuals under age 50. And in fact, when we look at individuals aged 20 to 49, there's been a 51% increase in colorectal cancer screening, what we call, or colorectal cancer rates, which we call early onset colorectal cancer, since the year 1994. We call this a birth cohort effect, which I feel was best demonstrated in this slide that was presented by Caitlin Murphy at DDW last month. As you can see in this figure, for every year of birth from 1960 onward, there's increasing risk of colorectal cancer. So literally, for every individual who was born after 1960, your risk of colorectal cancer has gone up each year. And I feel that this right here in this image is the most compelling data to suggest that risk factors that we are seeing in early life are driving the changing epidemiology of disease. And we call this the X factor now, is what have we exposed ourselves to in the 1960s and 70s that is causing polyps and cancers to occur more early in human beings. And I think we've had a lot of theory, but we have not quite figured out what is driving this changing epidemiology. It was this trend, however, that prompted the American Cancer Society to recommend screening at age 45 in 2018. They were the first major society to do this, and they commissioned several modeling studies to inform their decision. They made what they call a qualified recommendation, saying that there was certainly some data to suggest that we should screen everyone starting 5 years earlier. However, there was a lot of challenge in implementing this recommendation. First of all, they were the only society making this recommendation. There certainly was not insurance coverage across the board for individuals who were coming to their doctors asking for screening at age 45. And quite frankly, we were already struggling to screen individuals who are age 50 and older. So this really didn't stick. And it took 2 additional major studies and 3 additional years for us to get to the recommendations we saw last month from the United States Preventive Service Task Force. They also commissioned 2 reports to come up with their final recommendations. The first was a systematic review to evaluate the benefits and harms of screening in adults age 40 years and older. So they were looking at screening as early as 40. They also commissioned a comparative modeling report from the CISNET Colorectal Cancer Working Group to look at life years gained, colorectal cancer cases and deaths that are averted, the burden required of colonoscopy, and the harms for different starting and stopping ages for various screening strategies. They actually, see if I can, perfect. So the systematic review, again, was the first study that they commissioned, and it's an incredible document. It's a 100-page document, but it's the most up-to-date synthesis of information that we have regarding screening test accuracy and the harms of screening. They included, at the end, 70 studies in this systematic review, and these are just new studies since the year 2016 when they had the last screening guideline. And these studies include direct visualization, like colonoscopy, but they also looked at stool-based screening, the serum studies, and also one urine-based screening test. They also reviewed whether test effectiveness varied by age, gender, and also race, ethnicity. From this systematic review, they concluded that currently used screening modalities have different levels of evidence and support their use, different test performance to detect cancer and precancer lesions. And the recommendation regarding which screening tests to use are not uniform and should depend on the decision maker's criteria of evidence and weighing the net benefit. So again, strongly suggesting that this is a patient-provider decision. The modeling analysis that was used for the most recent screening guideline compared to the modeling analysis that was used in 2016 is also quite different. They commissioned 3 microsimulation models. These are listed here on the slide. Those are not different than the models that they used in 2016. The key difference from 2016, however, is that they used the data on the changing epidemiology of disease to inform how the models are functioning. So they better accounted for the increase in colorectal cancer screening rates in individuals under the age of 50. So this third-party analysis team is using data that reflects the recent population trends in colorectal cancer incidence. And that's why the results that they came out with are quite different from the analysis results from 2016. I'd like to point out that they did emphasize looking at race and sex, and that the modeling results did not change when we were looking at men versus women or whites versus blacks. So although historically some societies such as ACG have recommended earlier screening in African Americans, the most recent data does not support that any group, any gender or race ethnic group, benefits from screening at an age earlier than 45 currently, and that's obviously considering just the data that we have. It's important to mention a few words as well about when to stop screening, as this is another very critical debate in colorectal cancer screening that was discussed at DDW 2021. While there is strong evidence to support screening initiation at 50 and now some evidence for 45, there is really uncertain evidence as to whether there is a benefit of screening individuals after the age 75. So here on this slide, I've listed the factors that the United States Preventive Task Force and others recommend we consider when we are consulting with a patient who is between the ages of 76 and 85 as to whether they should continue screening. Those consider CRC risk, whether they've had prior screening, their life expectancy, specifically their comorbidities, and also the patient's preference. There are actually several online calculators where you can input a lot of this information about your patient, and it will tell you if the benefits of screening outweigh the harms. One in particular is a tool that is called ePrognosis that comes out of UCSF. I will say that many of these are imperfect. So the ePrognosis one, for example, it's a great tool. I've used it actually in my clinic with my fellows, but it doesn't take into account history of prior screening. And that is one of the things that, if anything, we think might be a critical distinction as to whether you would screen a 77-year-old. A 77-year-old who's never had any prior screening, who's rather healthy, might benefit from more than a 77-year-old who's been screened up to that date. All of this is because we know that there is excess risk of colonoscopy complications when we screen individuals beyond the age of 75. This figure, also presented at the DDW meeting, demonstrates the age-specific excess risk of complications from colonoscopy with polypectomy relative to colonoscopies without polypectomy. And as you can see, the risk of complications, which include serious gastrointestinal events, other gastrointestinal events, and cardiovascular events, increases dramatically, and especially after age 75. It literally takes off at that point. And this is why we are so concerned when we screen older or more senior adults. So generally what I would say, and Joe Anderson emphasized this at the DDW meeting, is that the movement in our field is currently away from screening older adults. And the one exception probably being individuals who've never had any prior screening. That might be the group that benefits most from a screening test between ages 76 and 85. So now I want to pivot to another topic within the realm of colorectal cancer screening that we felt it was important to cover today. There have been several advancing technologies within gastroenterology, and many of these are aimed at improving colorectal cancer prevention and control. As Dr. Izaka mentioned in her talk, we learned at DDW 2020 from Peter Lang's group that inclusion of serum-based colorectal cancer screening tools has the potential to increase overall screening uptake, especially among those who have declined colonoscopy and FIT. Although many of the serum assay studies are still being developed and are not optimal yet, they're not approved for general use, but once they are optimized, we do feel that this will largely change the landscape of offerings for colorectal cancer screening and potentially the lives that we're able to save, reducing the burden of this disease. We also learned at DDW from this study from Lohman's group that serum-based colorectal cancer screening tests are getting better and better with time, and that they can be effective for detecting early onset colorectal cancer. Here, a methylated septin-9 assay was both sensitive and specific for cancers in early onset populations. Most of these tests, as I mentioned, are still under development. There's several companies that are making these, including Epidemiology, Freenome, Exact, Grail, Abbott, Quest, and all of them are working on refining their assay, many of them in the second generation of their blood serum test. And we're still trying to figure out how to optimize the sensitivity and specificity of these tests, but also how to incorporate them in the armamentarium of testing offerings that we give to our patients. Besides screening test innovation, the other areas of colorectal cancer screening for which there have been many technological advancements is in the quality of colonoscopy. In 2015, the ASGE and ACG task force established several quality indicators that are specific to screening colonoscopy. They're really designated to optimize the detection of adenomas, and also now we're also focusing on sessile serrated polyps, and also drive down colorectal cancer incidence and mortality. These QIs emphasize that there must be a standard for high-quality endoscopy or colonoscopy, and they have been associated with better outcomes for patients. Screening colonoscopy, because of this, has seen a rush of new technologies that are aimed to ease the mechanics of colonoscopy, either through increasing visualization or just making it easier for us to drive the scope. So these include retroview colonoscope systems, panoramic devices, and devices that help stent open the colonic folds, and these are commonly used in practice today. Many of you are probably using some of these tools at your home institutions. Now we have several studies that have formally evaluated the effectiveness of these tools, and they've been shown over and over, many of them, to increase ADR, again, which is a critical colonoscopy quality indicator. Artificial intelligence, or AI, is also gaining applications in colonoscopy and screening colonoscopy. AI is a branch of computer science that attempts to mimic or improve upon the intelligence and the behavior of human beings. And it's an emerging field throughout medicine, but is also starting to take hold in gastroenterology. For us specifically, we've been using it in the landscape of screening colonoscopy to improve colorectal polyp detection rates, polyp characterization, including histology, and to drive management of patients who have findings on their endoscopies. We've seen years of development of these systems, and now is the time when they've become quite sophisticated and they're starting to be used in practice. And these advancements were highlighted through several abstracts, posters, and presentations at DDW. I thought this slide was particularly beautiful. It was presented by Pratik Sharma during DDW 2021, and it really just outlines the quality metrics that AI can impact from the pre-procedure. So starting at even just looking at domains like the rate of the accurate bowel prep, but all the way through to post-procedure. So looking at your post-polypectomy surveillance recommendation. This slide, I thought, just well encapsulated a preview or an overview of the many ways that artificial intelligence will likely influence colonoscopy quality in the near future. And in the next few slides, I'm going to walk through what screening colonoscopy in particular might look like not too long from now. I'll use a combination, I'm borrowing 2 sets of slides that were shared at DDW by Tyler Burzin and Pratik Sharma. And what we're going to see in these series of slides are that AI tools can be useful to do everything from the beginning to the end of your procedure. So for example, AI can be used to record the starting time of a procedure. It does this by automatically recognizing the anal verge and or the rectum. AI tools are capable of measuring the bowel prep quality. So these systems literally can look at the bowel prep. They can objectively and consistently rate the bowel prep scores, and that's using either the Boston or the Ottawa score. And they give you a bowel prep rating every 30 seconds as you advance the colonoscope. They also can provide a cumulative score for the bowel prep over the entire duration of the procedure and during the withdrawal phase of the colonoscopy. There's at least one published study by Zhao et al. That has demonstrated that these AI measures are more consistent and more accurate than humans rating bowel prep. These AI systems are also capable of recognizing and photo-documenting important landmarks, including the cecum and the ileocecal valve. And all of this is happening without pressing any buttons. It is automatically telling you where you are in the colon, and it is automatically taking those photos and labeling for them while you're doing your procedure. And providing the time marks for landmarks like the cecum and the ileocecal valve, these systems can automatically measure your withdrawal time. As you can see here, there's a speedometer that actually shows on the monitor, and it can tell the endoscopist if they're going too fast and evaluating the colon as they're withdrawing the scope. And probably one of the most clinically relevant features of some of these programs is their ability to actually detect polyps themselves. So this is the idea that you could blindly advance the scope and the AI will tell you when you've hit a polyp, lighting it up with a box like this. One step further, and before I go to that one step, these tools have actually been evaluated in systematic and meta-analyses that have shown that AI is actually better at detecting polyps than humans are. So in this systematic review by Barua et al., they found that AI-based polyp detectomy systems increase both polyp detection rates and adenoma detection rates. So for example, ADR was 30% with the AI compared to 19% without the AI. They are also better at detecting small polyps, although in this systematic review it did not show a significant difference in their ability to detect advanced adenomas. So this is what I was saying is one step further. More so than even just finding the polyp for you, these AI tools can actually characterize the polyp for you. So here on this slide, the AI is putting a box around your polyp for you. It's actually defining the polyp phenotype. It's telling you the size of the polyp, so you don't have to guess that anymore. And it's also performing what we call optical pathology of the polyp. So it will tell you with certain certainty, as you can see on this slide, the likelihood that that polyp is an adenoma. So here the AI is highlighting polyps. So again, without you pressing a button, it's finding the polyps, and it's telling you which ones are adenoma versus non-adenomatous polyps. And finally, the AI can record the end time of the procedure and document the last anal verge image on removal of the scope, which is then used to calculate your withdrawal time. So as Dr. Berzin emphasized at the DDW meeting, AI has the potential to dramatically impact the clinical workflow around screening colonoscopy. So this is what it used to look like for us. We would do the colonoscopy, we'd wait a few days, the pathology report would come in. At that point, we could update the EHR, we could finally write the letter to the patient, we could notify the patient when they needed to come in for the next surveillance exam. In the future, with AI, it would look much more fine-tuned and streamed like this, where at the time of the colonoscopy, the AI itself would do all of this for you. So imagine when you're done with your procedure, it's documented all of your quality indicators for you. It's recorded and photo documented all the landmarks for you. It's actually recorded your withdrawal time and your ADR, and it's also given you a report, pre-written for you a report that you can review and edit and sign. So this is the future for what screening colonoscopy might look for some of us. I'm almost done, but I just want to make a couple more points. There are potential downsides for the artificial intelligence. We're excited about much of this technology, and we think that it can improve quality of colonoscopy and the number of polyps and adenomas we detect. But there obviously is the potential for false positive findings, missed lesions. Some of these algorithms have biases that can lead to differences in detection. There is also variable access to AI technology by income, health center, race, ethnicity, which may lead to greater disparities by income and race ethnicity. And also, there's a concern that it will lead to diminishing procedural skill, of course, if we become dependent on these technologies. So in summary, the new USPSTF screening guidelines recommend that we start screening individuals at age 45 at a grade B, or otherwise known as covered recommendation. The age to stop remains debated, but we do firmly feel that you should not be screening anyone after age 85. High quality colonoscopy, as we both have emphasized, is essential to reduce interval cancers, reduce morbidity and mortality. And the emerging technologies in colorectal cancer screening aim to improve the detection of early cancers and polyps and to improve colonoscopy quality. Thank you very much.
Thank you, Fola. So